Chapter 8: The Move to an Outcome Competency-Based Approach. An important trend is the move from an emphasis on the process of teaching and learning to the product and what is achieved. An important trend in medical education. The most important responsibility teachers have is to identify the learning outcomes or competencies expected of their students or trainees and to ensure that these can be achieved in the education program. Traditionally, medical education has focused on teaching methods such as the lecture and small group work on the design of the curriculum and whether, for example, it was community-based or integrated, and on the assessment of the learner and the different approaches adopted. What has been described as the most important trend in medical education in the past decade is the move towards an outcome competence-based approach where the emphasis is on the product of the learning rather than on the process. The concept of outcome-based education was promoted by Spady. He defined OPE as a way of designing, developing, delivering, and documenting instruction in terms of its intended goals and outcomes. Spady suggested that exit outcomes are a critical factor in designing the curriculum. You develop the curriculum from the outcomes you want students to demonstrate rather than writing objectives for the curriculum you already have. OPE can be summed up as results-oriented thinking. This shift towards OPE is at least in part analogous to the total quality movement in business and manufacturing. Outcome competency-based education is a performance-based approach at the cutting edge of curriculum development and offers a powerful way of changing and managing medical education. An outcome-based approach has been adopted by regulating and accrediting bodies such as the General Medical Council in the UK, the Accreditation Council for Graduate Medical Education in the United States, and the Royal College of Physicians and Surgeons of Canada. Standardizing of learning outcomes was one of the 4 key recommendations for programmatic reform of medical education advocated in the Carnegie Review of Medical Education in the United States. What is outcome competency-based education? OBE-CBE requires that the learning outcomes, competencies expected at the end of training and at the end of each phase of training are clearly stated, explicit and communicated to all concerned, including teachers, students, and other stakeholders, such as employers in the health service. Decisions about the curriculum, including the content, the educational strategies, the teaching methods, and the assessment are based on the agreed learning outcomes, competencies. These define what is taught, how it is taught, and how it is assessed. They may even influence the selection of students for admission to medical studies. There is a collectively endorsed vision that reflects a commitment that students will succeed. The learner's achievement of the exit outcomes before they leave the program of training is more important than the time spent in the program. In OPE, what is fixed is the outcomes or standards achieved with the time spent achieving these variables. In time-based training, what is fixed is time, and what is variable is the standard or outcomes achieved. In this text, we have not differentiated learning outcomes and outcome-based education from competencies and competence-based education. Although some workers have chosen to make a distinction, this serves no useful purpose and there is little value in doing so. The International Competency-Based Medical Education collaborators have been working since 2009 to provide an understanding of competency-based medical education and to accelerate its uptake worldwide. CBE has been defined as an approach to preparing physicians for practice that is fundamentally oriented to graduate outcome abilities and organized around competencies derived from an analysis of societal and patient needs. It emphasizes time-based training and promises a greater accountability, flexibility, and learner-centeredness. The idea of a competency-based program in medicine was introduced by McGahey at REI in 1978, but at that time had little impact in medical education. Before we explore further the concept of OPE and how learning outcomes can be identified and grouped in domains within an overall framework, we will look at the reasons why an outcome or competency-based approach has now been widely adopted in medical education. Figure 8.1 curriculum decisions are based on the learning outcomes. Educational environment. Learning outcomes, what to learn content, how to learn methods and strategies, assessment, support, student. Why an outcome competency-based approach? While formal evidence for the effectiveness of oak in medicine may be lacking, there are a number of strong reasons for the adoption of the approach. Oak offers major advantages, some of which are obvious, others are less so. Oak highlights the competencies achieved by the learner. What matters are the competencies and abilities achieved by doctors, including their knowledge, skills, and attitudes, rather than how they were trained or how they acquired these competencies. This has been described as education for capability. In the analogy of buying a car, the customer is more interested in how the car performs, its features and fuel consumption, and how easily it can be maintained rather than details of the manufacturing process. As Thomas Fuller noted, a good archer is not known by his arrows but by his aim. Oak is necessary given the rapid advances in medicine. Knowledge in the biomedical field is doubling every 18 months. For this reason, it is no longer feasible to cover all aspects of a subject in the curriculum. While the amount of knowledge has greatly increased, the length of the undergraduate curriculum has remained the same at 4, 5, or 6 years duration. It is now more important than ever that as teachers we agree and advise our students about the core competencies and knowledge we expect them to master in the time available. OBE ensures consideration is given to important topics that otherwise might be neglected. In the past, there have been many areas that have been ignored in the curriculum, resulting in gaps in the student's competence and errors in practice. Subjects neglected include attitudes and professionalism, communication skills, health promotion, team working, patient safety, and management of errors. OBE helps to ensure that these areas are considered alongside other key topics. OBE emphasizes accountability and transparency in medical education. Demands for greater accountability, quality assurance, and transparency are features of medical education today. OBE focuses attention on standards achieved and not on time spent in training. An OBE approach to curriculum planning also encourages a debate regarding the aims of medical education and what is required of a good doctor. This may include, in addition to the provision of quality care for individual patients, an element of social responsibility or accountability in medicine and the development of the doctor as a global citizen. OBE empowers students and points them in the right direction. OBE provides a robust framework for the curriculum and can be thought of as the glue that holds the curriculum together. It is consistent with a move to a student-centered approach and provides students with a clear idea of what is expected of them. Traditionally, when students embarked on their medical training, it was more like a magical mystery tour. They lacked an understanding of what was expected of them at the different stages of their education. The provision of a clear set of learning outcomes empowers the students and engages them more actively with the curriculum. OBE provides the basis for the allocation of resources to providers. The contribution made by a course or subject to the overall learning outcomes can help to determine the allocation of time and resources to individual courses. In one medical school, it was proposed that the duration of obstetrics and gynecology clerkship should be reduced significantly, given that the competence in the delivery of a baby was no longer an undergraduate requirement. The proposal was quashed when the contributions of the clerkship to the school's overall learning outcomes was considered. Among other things, the course offered students valuable opportunities at the antenatal clinics to understand health promotion and at the child and mother mortality conferences to appreciate clinical audit. OBE ensures that the assessment is more valid. OBE has particular significance for student assessment, and the approach helps to ensure greater validity of the assessment. OBE is consistent with the move to a more performance-based assessment and facilitates an assessment to a standard approach where it is the standards students achieve that are important and not the time they take to achieve them. OBE provides continuity across the continuum of medical education and need to have a more seamless continuum between the different phases of undergraduate, postgraduate, and continuing medical education is now accepted. OBE provides a standard language or vocabulary to plan the continuum and encourages continuity between the phases by making explicit the outcomes for each of the phases or stages of education. Learning outcomes provide a framework to anchor the education program from admission to medical school throughout the lifetime of a doctor. OBE flags up problems in the curriculum. Increasing attention has been focused on curriculum evaluation. Learning outcomes provide a yardstick against which a curriculum can be judged. A failure to achieve the agreed outcomes almost certainly identifies a problem with the curriculum. OAB helps teachers to select the appropriate topics to be taught in a teaching session. The expected learning outcomes guide a teacher as to topics to be covered in a teaching session. They should not be tempted to cover the aspects of the subject that are only of interest to them. In the early 17th century, the practice at Glasgow University was for teachers to do just that. They selected a book from their personal or the university's collection that interested them and read it to students in the lecture hall. The senior university position of reader exists even today, although the role is very different. In response to student protests, the concept of a planned curriculum with the clarity of the content to be addressed was developed. This was the first use of the word curriculum. OAB facilitates mobility of doctors and enables curricula in different countries to be compared. It is possible to compare education programs using statements of learning outcomes. The Bologna process is concerned with harmonization, not necessarily uniformity, in the higher education sector in Europe. And the Turing Project has as its aim the establishment of a learning outcome framework for primary medical degree qualifications in Europe. Myths and concerns about OAB. While OAB offers many advantages, the approach has also been misunderstood and criticized by some teachers and educators. Here are some of the common myths. Myth 1. OAB is concerned with detail and the big picture may be missed. Concern has been expressed that what a doctor does is far greater than can be described in competence terms. In the 1960s, Major and others introduced the idea of instructional objectives. The approach, however, had a disappointing impact on student learning. A contributing factor was the level of detail in which instructional objectives were specified. The Southern Illinois Medical School had a book of objectives extending to 880 pages. Moreover, the classification of objectives into knowledge, skills, and attitudes was inappropriate given the complexity of medical practice. These difficulties, however, do not exist with learning outcomes where the emphasis is on broader frameworks and the competencies required of a doctor. The three-circle or Scottish doctor framework, as described in Chapter 10, demonstrates how outcomes can be designed to specify broadly what is expected of a good doctor. Myth 2. OAB is a threat to the autonomy of the teacher and removes their freedom and independence. Concern has been expressed that defining education as a set of outcomes in advance imposes unnecessary constraints on the teacher. While this may be true in some fields, in medicine no one can disagree with the need for clarity as to what is expected from the doctor on completion of his or her training. Knowledge of the expected learning outcomes, far from limiting the role of the teacher, empowers teachers to devise their own program to meet these outcomes. Myth 3. OAB is contrary to trends in medical education. This concern was expressed particularly relating to problem-based learning, where task for a PBL student group is to determine, in relation to a problem, their learning requirements. There is the need, however, within the context of PBL for students to be aware of how a study of the individual problem relates to the overall course outcomes. The move to OAB strongly supports a more student-centered approach to learning with what the student has to learn clearly identified, their progress based on their demonstrated achievement, their needs accommodated through different instructional strategies, and each student provided time and assistance to realize their potential. Myth 4. OAB is about minimum competence and excellence is ignored. There is concern that expressing the education program in relation to what all students should achieve may set only minimum expectations and discourage higher achievements. As demonstrated at Brown Medical School, however, this need not be so with the student requirements set at 3 levels: beginner, intermediate, and advanced. Students have to achieve all outcomes at the beginner level, some at the intermediate level, and at least a few at advanced level. In a competency-based curriculum, it is possible for students to move on to more advanced studies when they complete the program at the basic level. This is explored further in chapters 3 and 15 in the context of adaptive learning. With 5, OAB is labor-intensive and the time required cannot be justified. The specification of learning outcomes and the implementation of an outcome-based curriculum does require time and effort. Much of this work, however, needs to be undertaken regardless of the educational strategy adopted. It is necessary if there is to be an authentic curriculum as described in Chapter 12. The benefits to be accrued, as highlighted in Box 8.1, significantly outweigh any disadvantages. Hope is not simply a passing fad and is now part of mainstream medical education. Box 8.1 Features of outcomes-based education. Specifications of learning outcomes. A broad framework of outcomes and competencies. A vocabulary to facilitate collaboration in medical education. Specification at different levels possible. A curriculum based on specified learning outcomes. Freedom for teachers. Empowerment for learners. Time commitment rewarded. A response to challenges facing medical education. Entrustable professional activities. What is an EPA? Entrustable professional activities, a concept introduced in 2005 by Orchen. Kate have a role to play alongside learning outcomes and competencies in specifying what learners are expected to achieve. Learning outcomes and competencies describe the attributes and the abilities of the student or doctor. An EPA is different. It represents a unit of work and can be defined as a unit of professional practice that can be entrusted to a sufficiently competent learner or professional. The question asked in an EPA is whether the learner has the requisite competencies to carry out a specified task. Examples of EPAS reported in the literature include providing preoperative assessment, providing palliative care, managing common gastrointestinal infections, and conducting a risk assessment. In the United States, the Association of American Medical Colleges has suggested 13 EPAS relevant for undergraduate education. Granularity and EPAS. EPAS, as highlighted by Tenkate, may be small, e.g., measuring the blood pressure or taking a history from the patient, or large, e.g., carrying out a routine checkup of a stable adult patient or managing a clinical ward. There is an issue relating to the size or granularity of an EPA. The danger in specifying too many small EPAs is that this may result in the same fate as befell instructional objectives, where the large number of objectives became unmanageable and too difficult to apply in a practical context. The EPA should be sufficiently large, for example, routine checkup of a stable adult, that it represents a significant step. Smaller EPAs may be combined to form a broader EPA. Figure 8.2 Each EPA requires a number of learning outcomes or competencies. Smaller EPAs may be nested in a broader EPA. Learning outcomes, competency 1, 2, 3, 4, 5. EPA 1, 2, 3, 4. Relationship between an EPA and learner outcomes and competencies. An EPA requires the learner to integrate multiple competencies from different domains. Each EPA requires a number of learning outcomes or competencies. Combining together the learning outcomes from the different domains in a holistic approach to the patient is a feature of the three-circle or Scottish doctor learning outcome framework described in Chapter 10. An EPA, for example, taking and recording a patient's history requires mastery of outcomes from at least 5 domains in the three-circle model. These include Domain 1 clinical skills, Domain 2 communication skills, Domain 7 information handling skills, Domain 8 in understanding of clinical medicine, and Domain 9 attitudes and professionalism. The relationship between EPAS and learning outcomes or competencies can be set out as a matrix. EPAS and specification of the level of supervision. A feature of an EPA is that the level of supervision required at the given point in the training program and against which the student will be assessed is specified. This may be classified as the ability to 1. Perform under direct supervision with the supervisor present. 2. Perform under indirect supervision with the supervisor not in the same room but immediately available. 3. Perform with the supervisor available at a distance. 4. Perform with no supervisor, EPAS and the curriculum. Just as a curriculum can be designed around a series of learning outcomes or competencies, it also may be possible to design a curriculum around a set of EPAS. A comprehensive set of EPAS can contribute to the specification of the education program. In this respect, EPAS are similar to the tasks in task-based learning which, as described in Chapter 16, can serve as a curriculum framework. It is important to recognize, however, that a curriculum cannot be constructed simply in terms of EPAS. Some learning outcomes covered in a curriculum are not addressed in EPAS. For example, the development of the professional identity of a doctor, the ability to monitor personal performance, and the ability to manage personal learning and to keep up to date.